This chapter 16 is from Timby Fundamentals, Fluid and Chemical Balance. Body fluid is a mixture of water, chemicals called electrolytes and non-electrolytes, and blood cells. Water, the vehicle for transporting the chemicals, is the very essence of life. Because water is not stored in any great reserve, daily replacement is the key to maintaining survival. This chapter discusses the mechanisms for maintaining fluid balance and restoring fluid volume and the components in body fluid. Water. Depending on age and gender, the human body comprises approximately 45% to 75% water. Body water normally is supplied and replenished from three sources: drinking liquids, consuming food, and metabolizing nutrients. Once the water is absorbed, it is distributed among various locations called compartments within the body. Fluid compartments. Body fluid is located in two general compartments. Intracellular fluid, fluid inside the cells, represents the greatest proportion of water in the body. The remaining body fluid is extracellular fluid, fluid outside the cells. Extracellular fluid is further subdivided into interstitial fluid, which is fluid in the tissue space between and around cells, and intravascular fluid, the watery plasma or serum portion of blood. The percentage of water in these compartments varies according to age and gender. See Table 16.1. Electrolytes are chemical compounds such as sodium and chloride that possess an electrical charge when dissolved, absorbed, and distributed in body fluid. They are essential for maintaining cellular tissue and organ functions. For example, electrolytes affect fluid balance and complex chemical activities such as muscle contraction and the formation of enzymes, acids, and bases. Electrolytes are obtained from dietary sources of food and beverages, but may be provided through pharmaceutical supplements for clients who are not eating or cannot do so. Electrolytes are decreased, for example, through malnutrition or an altered state of health, such as vomiting and diarrhea, severe burns, disorders like renal disease, even medications like diuretics. Mobility limitations, cognitive impairments, and difficulty performing activities of daily living can lead to fluid and electrolyte deficits in older adults. Collectively, electrolytes are called ions, substances that carry either a positive or negative electrical charge. Cations, electrolytes with a positive charge, and anions, electrolytes with a negative charge, are present in equal amounts overall, but their distribution varies in each body fluid compartment. For example, more potassium ions are present inside the cells than outside. Electrolytes are measured in the serum of blood specimens, and the amount is reported in milliequivalents, M, capital E, small q. When one or more cations or anions become excessive or deficient, an electrolyte imbalance occurs. Significant imbalances can lead to dangerous physiologic problems. In many situations, electrolyte imbalances accompany changes in fluid volumes. Non-electrolytes are chemical compounds that remain bound together when dissolved in a solution and do not possess an electrical charge. The chemical end products of carbohydrates, proteins, and fat metabolism, namely glucose, amino acids, and fatty acids, provide a continuous supply of non-electrolytes. In the absence of metabolic disease, a stable amount of non-electrolytes circulate in body fluid as long as a person consumes adequate nutrients. Deficiency states occur when body fluid is lost or when the ability to eat is compromised. Fluid transport mechanisms. Although fluid compartments are identified separately, water and the substances dissolved therein continuously circulate through all parts of the body. Physiologic transport mechanisms such as osmosis, filtration, passive diffusion, facilitated diffusion, and active transport govern the movement and relocation of water and substances within body fluid. Osmosis helps regulate the distribution of water by controlling the movement of fluid from one location to another. Under the influence of osmosis, water moves through a semi-permeable membrane, like those surrounding body cells, capillary cells, and body organs and cavities, from an area where the fluid is more dilute to another area where the fluid is more concentrated. Once the fluid is of equal concentration on both sides of the membrane, the transfer of fluid between compartments does not change appreciably except volume for volume. The presence and quantity of colloids on either side of the semipermeable membrane influence osmosis. Colloids are undissolved protein substances such as albumin and body cells within body fluids that do not readily pass through membranes. Their very presence produces colloidal osmotic pressure, the force for attracting water, that influences fluid volume in any given fluid location. Filtration, another mechanism that influences fluid distribution, regulates the movement of water and substances from a compartment where the pressure is higher to one where the pressure is lower. The force of filtration is referred to as hydrostatic pressure, the pressure exerted against a membrane. For example, because of contraction of the left ventricle, the fluid pressure is higher at the arterial end of a capillary than at the venous end. Consequently, fluid and dissolved substances are forced into the interstitial compartment at the capillary's arterial end. Water is then reabsorbed from the interstitial fluid in comparable amounts at the venous end of the capillary because of colloidal osmotic pressure. Filtration also governs how the kidney excretes fluids and wastes and then selectively reabsorbs water and substances that need to be conserved. Passive diffusion is the physiologic process in which dissolved substances such as electrolytes and gases move from an area of higher concentration to an area of lower concentration through a semipermeable membrane. It occurs without any expenditure of energy, hence the word passive. Passive diffusion facilitates electrochemical neutrality, an identical balance of cations with anions in any given fluid compartment. Like osmosis, passive diffusion remains fairly static once equilibrium is achieved. Facilitated diffusion is the process in which certain dissolved substances require the assistance of a carrier molecule to pass from one side of a cellular membrane to the other. Facilitated diffusion distributes substances from an area of higher concentration to one that is lower. Glucose is an example of a substance that requires facilitated diffusion because once in the bloodstream, glucose cannot permeate cell walls. Glucose is made available to cells in combination with insulin and glucose transports called GLUT proteins located within cellular membranes. GLUT is rapidly stimulated. The GLUT proteins bind with glucose in the plasma on the outside of the cell membrane, and then glucose transporters face the inner area of the cell, and the glucose moves into the cell. Active transport. Active transport, a process of chemical distribution that requires an energy source, involves a substance called adenosine triphosphate, ATP. ATP provides energy to drive dissolved chemicals against the concentration gradient. In other words, it allows chemical distribution from an area of low concentration to one that is higher, the opposite of passive diffusion. An example of active transport is the sodium-potassium pump system on cellular membranes, which regulates the movement of potassium from lower concentrations in the extracellular fluid into cells where it is more highly concentrated. It also moves sodium, which has a lower concentration within the cells, to extracellular fluid where it is more abundant. Fluid regulation. Fluid regulation. In healthy adults, fluid intake generally averages approximately 2,500 milliliters per day, but it can range from 1,800 to 3,000 milliliters per day with a similar volume of fluid loss. Normal mechanisms for fluid loss are urination, bowel elimination, perspiration, and breathing. Losses from the skin and other areas other than where sweat glands are located and from the vapor and exhaled air are referred to as insensible losses because they are, for practical purposes, unnoticeable and unmeasurable. Under normal conditions, several mechanisms maintain a match between fluid intake and output, called I&O. For example, as body fluid becomes concentrated, the brain triggers the sensation of thirst, which then stimulates the person to drink. As fluid volume expands, the kidneys excrete a disproportionate volume of water to maintain or restore proper balance. There are circumstances, however, in which oral intake or fluid losses are altered. Therefore, nurses assess clients for signs of fluid deficit or excess, particularly in those prone to fluid imbalances. See box 16-1 on page 315. Conditions that predispose to fluid imbalances, fluid deficits, starvation, impaired swallowing, vomiting, gastric suction, diarrhea, laxative abuse, potent diuretics, hemorrhage, major burns, draining wounds, fever and sweating, exercise and sweating, environmental heat and humidity. Fluid excess is caused by kidney failure, heart failure, rapid administration of IV fluid or blood, administration of albumin, corticosteroid drug therapy, excessive intake of sodium, pregnancy, and premenstrual fluid retention. Fluid volume assessment. Nurses assess fluid status using a combination of a physical assessment, table 16.4, and a measurement of INO volumes. Intake and output is one tool to assess fluid status by keeping a record of the client's fluid intake and fluid loss over a 24-hour period. Agencies often specify the types of clients that are placed automatically on INO. Generally, they include the following: clients who have undergone surgery until they are eating, drinking, and voiding in sufficient quantities, clients receiving intravenous IV fluids, clients receiving tube feedings, clients with some type of drainage or suction equipment, clients with urinary catheters until it can be determined that output is adequate or they are voiding well after removal of the catheter, clients undergoing diuretic drug therapy. In addition, many agencies allow nurses to independently order an INO assessment for clients who have or are at risk for a fluid imbalance problem. The nurse discontinues the nursing order when the assessment is no longer indicated but consults with the physician if it has been medically ordered. Each agency has a specific INO form kept at the bedside so that nurses can conveniently record the type of fluid and amounts that are consumed and lost throughout the day. The nurse subtotals the amounts at the end of each shift or more frequently in critical care areas. He or she documents the grand total in a designated area in the medical record, for example, on the graphics sheet with other vital sign information. Signs of fluid imbalance. Weight. Fluid deficit would be a weight loss of greater or equal to 2 pounds in 24 hours. Fluid excess would be weight gain of greater than or equal to 2 pounds in 24 hours. Blood pressure. Fluid deficit would cause low blood pressure. Fluid excess would cause high blood pressure. Temperature. Fluid deficit would be elevated. With fluid excess, it would be normal. Pulse. Rapid, weak, and thready for fluid deficit. Full and bounding with fluid excess. Respirations. Rapid and shallow in fluid deficit. Moist, labored in fluid excess. Urine would be scant and dark yellow with fluid deficit. In fluid excess, it will be light yellow. Stool, dry, small volume with fluid deficit, fluid excess, bulky. Skin, warm, flush, dry, porous skin turgor would be fluid deficit, and cool, pale, moist, pitting edema would be fluid excess. Mucous membranes, dry and sticky for fluid deficit, moist for fluid excess. Eyes, sunken with fluid deficit, swollen with fluid excess. Lungs, clear with fluid deficit, crackles and gurgles with fluid excess. Breathing, effortless with fluid deficit, dyspnea and orthopnea with fluid excess. Energy for fluid deficit, weak, and fluid excess would be fatigues easily. Jugular neck veins would be flat with a fluid deficit and distended with a fluid excess. Cognition would be reduced with fluid deficit and reduced also for fluid excess. Consciousness would be sleepy for fluid deficit and anxious for fluid excess. Fluid intake is the sum of all fluid volume that a client consumes or is instilled into the client's body, including the following: all the liquids a client drinks, the liquid equivalent of melted ice chips, which is half of the frozen volume, foods that are liquid by the time they are swallowed, such as gelatin, ice cream, and thin cooked cereal, fluid infusions such as IV solutions, fluid installations such as those administered through feeding tubes or tube irrigations. Fluid volumes are recorded in milliliters. The approximate equivalent for 1 ounce is 30 milliliters, a teaspoon is 5 milliliters, and a tablespoon is 15 milliliters. Packaged beverage containers such as milk cartons usually indicate the specific fluid volume on the label. Hospitals and nursing homes commonly identify the volume equivalents contained in the cups, glasses, and bowls used to serve food and beverages from the dietary department. If an equivalency chart is not available, the nurse uses a calibrated container to measure specific amounts. Estimated volumes are considered inaccurate. Dehydration in older adults may be a consequence or indicator of abuse or neglect. Older adults may need to be encouraged to drink because even at times when they do not feel thirsty, because age-related changes may diminish the sensation of thirst. Rather than asking older adults if they would like a drink, it is important to identify their preferences and offer small amounts of their preferred liquids at frequent intervals. This intervention will assist in keeping oral mucosa moist and providing hydration needs. To maintain adequate consumption of nutrients, it is best to offer fluids to older adults at times other than meals. Distending the stomach with liquids creates a sensation of satiety, which is fullness, and reduces the consumption of food. When older adults must fast before certain procedures, emphasize the need to increase oral fluid intake in the hours before beginning fluid restrictions to prevent dehydration. Encourage older adults to drink non-caffeinated beverages because of the diuretic effect of caffeine, or to replace the volume of caffeinated beverages by consuming the same volume of non-caffeinated fluids per day. Common fluid imbalances. Fluid compartments. Body fluid is located in 2 general compartments. Intracellular fluid, fluid inside the cells, representing the greatest proportion of water in the body. The remaining body fluid is extracellular fluid, fluid outside the cells. Extracellular fluid is further subdivided into interstitial and intravascular fluid. Fluid imbalance is a general term describing any of several conditions in which the water content of the body is not in the proper volume or location within the body. It can be life-threatening. Common fluid imbalances include hypovolemia, hypervolemia, and third spacing. Hypovolemia refers to the low volume of extracellular fluid. If untreated, it may result in dehydration, a fluid deficit in both extracellular and intracellular compartments. Mild dehydration is present when there is a 3 to 5% loss of body weight. Moderate dehydration is associated with a 6 to 10% loss of body weight, and severe dehydration, a life-threatening emergency, occurs with a loss of more than 9 to 15% of body weight. In addition to weight loss, dehydration is evidenced by decreased skin turgor. Hypervolemia. Hypervolemia means a higher than normal volume of water in the intravascular fluid compartment and is another example of a fluid imbalance. Edema develops when excess fluid is distributed to the interstitial space. When fluid accumulates in dependent areas of the body, those influenced by gravity, the tissue pits forms indentations when compressed. See Chapter 13 and also on page 318. Edema does not usually occur unless there is a 3-liter excess in body fluid. Hypervolemia can lead to circulatory overload, severe compromised heart function if it remains unresolved. Control of edema is an important nursing priority. Fluid balance is restored by the following: treating the disorder, contributing to the increased fluid volume, restricting or limiting oral fluids, reducing salt consumption, discontinuing IV fluid infusion, or reducing the infusing volume, administering drugs that promote urine elimination, and using a combination of these interventions. In addition, causes of fluid volume deficits include the following. This is deficits: inadequate fluid intake, fluid loss, and excess of fluid intake, translocation of large volumes of intravascular fluid to the interstitial compartment or to areas with only potential spaces such as the peritoneal cavity, pericardium, and pleural space. Fluid balance is restored by treating the cause of hypovolemia, increasing oral intake, administering IV fluid replacements, controlling fluid losses, or a combination of those measures. Then we discussed hypervolemia. Now we're going to discuss third spacing. Third spacing is the movement of intravascular fluid to non-vascular fluid compartments where it becomes trapped and useless. It generally is manifested by tissue swelling or fluid that accumulates in a body cavity such as the peritoneum. See figure 16.6 on page 319. Third spacing is associated commonly with disorders in which albumin, a plasma protein, levels are low because albumin facilitates colloidal osmotic pressure, retaining fluid within the vascular system. Causes of hypoalbuminemia, a deficit of albumin in the blood, include liver disease, chronic kidney disease, and disorders in which capillary and cellular permeability are altered, such as burns and severe allergic reactions. Depletion of fluid in the intravascular space may lead to hypotension and shock. Thus, fluid therapy becomes critical. The priority is to restore the circulating volume by providing IV fluids, sometimes in large volumes at rapid rates. Blood transfusions or the administration of albumin by IV infusion also are used to restore colloidal osmotic pressure to pull the trapped fluid back into the intravascular space. When this occurs, clients who were previously hypovolemic can suddenly become hypervolemic. The nurse closely monitors clients who receive albumin replacement for signs of circulatory overload. Restoring fluid volume. Treating the cause of hypovolemia, increasing oral intake, administering IV fluid replacements, controlling fluid losses, and using a combination of these measures. Reducing fluid volume. Treating the disorder contributing to the increased fluid volume, restricting or limiting oral fluids, reducing salt consumption, discontinuing IV fluid infusions or reducing the infusing volume, administering drugs that promote urine elimination, using a combination of the above interventions. Administering IV fluids. Maintain or restore fluid balance when oral replacement is inadequate or impossible. Maintain or replace electrolytes. Administer water-soluble vitamins. Provide a source of calories. Administer drugs. Replace blood and blood products. Complications associated with IV infusions are circulatory overload, an intravascular volume that becomes excessive, infiltration, the escape of IV fluid into the tissue, phlebitis, inflammation of a vein, thrombus formation, a stationary blood clot, pulmonary embolus, a blood clot that travels to the lung, infection growth of microorganisms at the site or within the bloodstream, and air embolism, a bubble of air traveling within the vascular system. Some medications such as diazepam, phenytoin, dopamine, and selected chemotherapy agents can injure soft tissue if the IV solution leaks from the vein. Supplies and protocols for treatment should be readily available when these IV drugs are given. The minimum quantity of air that may be fatal to humans is not known. Animal research indicates that fatal volumes of air are much larger than the quantity present in the entire length of infusion tubing. The average infusion tubing holds about 5 milliliters of air, an amount not ordinarily considered dangerous. Clients, however, are often frightened when they see air in the tubing, and nurses make every effort to remove air bubbles. It may be possible and advantageous to avoid using a tourniquet when accessing a vein that is visually prominent in an older adult. Use of a tourniquet may result in bursting the vein, sometimes referred to as blowing the vein, when it is punctured with a needle. Techniques for promoting vein distension. Apply a tourniquet or blood pressure cuff tightly around the arm. Have the client make a fist and pump the fist intermittently. Tap the skin over the vein several times. Lower the client's arm to promote distal pooling of blood. Stroke the skin in the direction of the fingers. Apply warm compresses for 10 minutes to dilate the veins and then reapply the tourniquet. Nurses need to closely monitor the response of older adults to IV infusions because they may have difficulty tolerating volumes that are safe for younger adults. Caring for the site. Because the venipuncture is a type of wound, it's important to inspect the site routinely. The nurse documents its appearance in the client's record. A common practice is to change the dressing over the venipuncture every 24 to 72 hours according to your agency's policy. Replacing equipment. Solutions are replaced when they finish infusing or every 24 hours, whichever occurs first. IV tubing is changed every 72 hours, depending on agency policy with some exceptions. Tubing used to instill parenteral nutrition is replaced daily. Tubing used to administer whole blood can be reused for a second unit if one unit is administered immediately after the other. Whenever tubing is changed, it is more convenient to replace both the solution and the tubing at the same time. Skill 16.5 describes how to replace just the tubing, which is generally more difficult. That's not true. Is the following statement true or false? Reducing salt consumption helps restore fluid volume. This is false. Reducing salt consumption does help reduce fluid volume. So this is true. Crystalloid solutions made of water and other uniformly dissolved crystals such as salt and sugar. Colloid solutions made of water and molecules, suspended substances such as blood cells and blood products such as albumin. Types of IV solutions. Isotonic contains the same concentration of dissolved substances as normally found in plasma. Hypotonic contains fewer dissolved substances than normally found in plasma. Hypertonic, more concentrated than body fluid and draws cellular and interstitial water into the intravascular compartment. These are examples of isotonic, hypertonic, and hypotonic. So the first one is isotonic, the second one is hypotonic, and the third one is hypertonic. Is the following statement true or false? Blood is an example of a crystalloid solution. False. Blood is an example of colloid solution. Types of tubing. Primary or secondary tubings for IVs, vented or unvented, microdrip or macrodrip chambers, unfiltered or filtered tubing, needle or needleless access ports. You can observe these pictures of these on page 322, 323, and 324. Then we have unvented and vented tubing. You want vented tubing if you're using a glass bottle, otherwise you would use an unvented tubing for a plastic bag. Techniques for infusing IV solutions: gravity, electronic infusion devices, infusion pumps, volumetric controllers. Gravity infusion is the most basic type of tubing that can be used for infusing a solution by gravity. The height of the IV solution rather than the tubing is the most important factor affecting gravity infusions. To overcome the pressure within the client's vein, which is higher than atmospheric pressure, the solution is elevated at least 18 to 24 inches above the site of the infusion. The height of the solution affects the rate of flow. The higher the solution, the faster the solution infuses, and vice versa. Electronic infusion devices. The two general types of electronic infusion devices are infusion pumps and volumetric controllers. Both are programmed to deliver a preset volume per hour. They trigger audible and visual alarms if the infusion is not progressing at the rate intended. They also sound an alarm when the infusion container is nearly empty, air is detected within the tubing, or an obstruction or resistance occurs in delivering the fluid. Infusion pumps. An infusion pump is an electronic infusion device that uses pressure to infuse solutions. This requires special tubing that contains a device, such as a cassette, to create sufficient pressure to push fluid into the vein. The machine adjusts the pressure according to the resistance it meets. This can be a disadvantage because if the catheter or needle within the vein becomes displaced, the pump continues to infuse fluid into the tissue until the machine's maximum preset pressure limit is reached. Volumetric controllers. A volumetric controller, an electronic infusion device that instills IV solutions by gravity, mechanically compresses the tubing at a certain frequency to infuse the solution at a precise preset rate. Volumetric controllers may or may not require special tubing. In some cases, when one container of fluid finishes infusing, the controller automatically resumes infusing another solution. The solution and tubing are prepared before accessing the vein with a needle or catheter. Skill 16.2 describes how to prepare IV solutions for administration. Venipuncture. Accessing the venous system by piercing a vein with a needle is a nursing responsibility when a peripheral vein, one distant from the heart, is used. When performing a venipuncture, the nurse assembles the needed equipment, inspects and selects an appropriate vein, and inserts the venipuncture device. Venipuncture devices. Several devices are used to access a vein. A butterfly needle, an over-the-needle catheter, most common, or a through-the-needle catheter. See Figure 16.13 on page 325. Venipuncture devices are available in various diameters or gauges. The larger the gauge number, the smaller the diameter. The diameter of the venipuncture device always should be smaller than the vein into which it is inserted to reduce the potential for occluding blood flow. An 18, 20, or 22 gauge is the size most often used for adults. In addition to a device for puncturing the vein, the following items are needed: clean gloves, a tourniquet, antiseptic wipes to cleanse the skin, a transparent dressing to cover the puncture site, and adhesive tape to secure the venipuncture device and tubing. Do not use antibiotic or antimicrobial ointment at the site because it may promote fungal infections or antibiotic resistance. An arm board may be needed to prevent the client from dislodging the venipuncture device. Vein selection. The veins in the hand and forearm are most commonly used for inserting a venipuncture device. See Figure 16.14. Scalp veins are used for infants and small children. Once the general site is selected, the nurse applies a tourniquet to select a specific vein. Box 16.5 identifies several techniques for promoting vein distension. Once the general site is selected, the nurse applies a tourniquet to select a specific vein. Box 16.5 identifies several techniques for promoting vein distension. A blood pressure cuff can be substituted for a rubber tourniquet. Whichever technique is used, the radial pulse should be palpable to indicate that the arterial blood flow is being maintained. Venipuncture device insertion. Skill 16.3 describes the technique for inserting an over-the-needle catheter within a vein. Infusion monitoring and maintenance. Once the venipuncture is performed and the solution is infusing, the nurse regulates the rate of infusion, assesses for complications, cares for the venipuncture site, and replaces equipment as needed. Regulating the infusion rate. The nurse is responsible for calculating, regulating, and maintaining the rate of infusion according to the physician's order. If an infusion device is used, the electronic equipment is programmed in milliliters per hour. If the solution is infused with an electronic infusion device by gravity, the rate is calculated in drops per minute. Formulas for calculating infusion rates are provided in box 16.6. For gravity infusions, the nurse counts the number of drops falling into the drip chamber per minute. By adjusting the roller clamp, the number of drops is increased or decreased until the infusion rate matches the calculated rate. Thereafter, the nurse monitors the time strip on the side of the container at hourly intervals to ensure that the infusion is instilling at the prescribed time. It may be possible and advantageous to avoid using a tourniquet when accessing a vein that is visually prominent on an older adult. Use of a tourniquet may result in bursting the vein, sometimes referred to as blowing the vein, when it is punctured with a needle. Assessing for complications. Complications associated with the infusion of IV solutions, Table 16.7, are circulatory overload and intravascular volume that becomes excessive, infiltration, the escape of IV fluid into the tissue, phlebitis, inflammation of a vein, thrombus formation, a stationary blood clot, pulmonary embolus, a blood clot that travels to the lung, infection, growth of microorganisms at the site or within the bloodstream, and air embolism, a bubble of air traveling within the vascular system. Inserting an intermittent venous access device. When the client no longer needs continuous infusions of fluid, when client needs intermittent IV medication, when client needs emergency IV fluid or medications. A picture of the intermittent venous access device. This is a sealed chamber that provides a means for administering IV medications or solutions periodically. It's inserted into a venipuncture device. An intermittent peripheral venous access device is also called a saline lock because the chamber is filled and periodically flushed with sterile normal saline to prevent blood from clotting at the tip of the catheter or needle. Central venous catheters are usually kept patent by flushing the device with heparinized saline. Intermittent venous access devices are used when the client no longer needs the continuous infusion, needs intermittent administrations of IV meds, may need emergency IV fluids or medicines if his or her condition deteriorates. These devices are replaced when the venipuncture site is changed. Skill 16.7 describes how to insert an intermittent medication lock when administering IV drugs is also discussed in Chapter 35. Blood administration. Blood is collected, stored, and checked for safety and compatibility before it is administered as a transfusion. Blood collection and storage. Blood donors are screened to ensure that they are healthy and will not be endangered by the temporary loss in blood volume. Refrigerated blood can be stored for 21 to 35 days, after which it is discarded. Blood safety. Once collected, the donated blood is tested for syphilis, hepatitis, and human immunodeficiency virus, antibodies to exclude administering blood that may transmit these blood-borne diseases. Blood that tests positive is discarded. Unfortunately, disease-carrying viruses may remain undetected if the antibodies have not reached a high enough level to be measured. The U.S. States Blood Safety Council, division of the Department of Health and Human Services, has policies regarding potential hepatitis C infection by blood transfusions. All blood collection agencies must notify people who received blood before 1987 if the donation came from a donor who has tested positive for hepatitis C since 1990. This policy is being implemented to promote early diagnosis and treatment of infected but asymptomatic transfusion recipients. The American Red Cross has a policy concerning blood donations to eliminate the potential transmissions of neurologic infectious organisms known as prions. Prions cause infectious microorganisms that cause various brain disorders, one of which is bovine spongiform encephalopathy, which is called mad cow disease because people who live in the UK, because blood is one possible mode of transmitting prions from animals to humans and humans to humans. The collection of blood is banned from anyone who has lived in the UK for a total of 3 months or longer since 1980, lived anywhere in Europe for a total of 6 months since 1980, or received a blood transfusion in the UK. America's Blood Centers and the American Red Cross ask prospective blood donors who may have been exposed to someone with Ebola to refrain from donating blood for 21 days following their last contact with the infected person. Blood compatibility. There are several hundred differences among the proteins in the blood of a donor and recipient. They can cause minor or major transfusion reactions. One of the most dangerous differences involves the antigens or protein structures on membranes of red blood cells. Antigens determine the characteristics of the blood group A, B, AB, and O, and Rh factor. Rh positive means the protein is present. Rh negative means that the protein is absent. Before donated blood is administered, the blood of the potential recipient is typed and mixed or cross-matched with a sample of the stored blood to determine whether the two are compatible. To avoid an incompatibility reaction, it is best to administer the same blood group and Rh factor. Exceptions are listed in Table 16-8 on page 329. Type O blood is considered the universal donor because it lacks both A and B blood group markers on its cell membrane. Therefore, type O blood can be given to anyone because it will not trigger an incompatibility reaction when given to recipients with other blood types. Persons with type AB blood are referred to as universal recipients because their red blood cells have proteins compatible with types A, B, and O. Rh positive persons may receive Rh positive or Rh negative blood because the latter does not contain the sensitizing protein. Rh negative proteins, however, should never receive Rh positive blood. Blood transfusion. Before administering blood, the nurse obtains and documents the client's vital signs to provide a baseline for comparison should the client have a transfusion reaction. Each client who receives blood has a color-coded bracelet with identifying numbers that must correlate with those on the units of blood. IV medications are never infused through tubing being used to administer blood. Blood transfusion equipment. There are certain standards for the gauge of the catheter or needle and the type of tubing used to transfuse blood. Catheter or needle gauge. Because blood contains cells, in addition to water, it is generally infused through a 16 to 20 gauge, preferably an 18, catheter or needle. Using a smaller gauge increases the potential for prolonging the infusion beyond 4 hours, and 4 hours is the maximum safe period for administering 1 unit of blood. Blood transfusion tubing. Blood is administered through tubing referred to as a Y set. Two branches are at the top of the tubing. One is used to administer normal saline and the other is used to administer blood. Normal saline, 0.9% NaCl, is the only solution used when administering blood because other solutions destroy red blood cells. The two branches of the Y set join above a filter that removes clotted blood and dead cell debris. The normal saline always is administered before the blood is hung and follows after the blood has been infused. It's also used during the infusion if the client has a transfusion reaction. Whenever a transfusion reaction is suspected or identified, the nurse's first step is to stop the transfusion, thereby limiting the amount of blood to which the client is exposed. Transfusion reactions. Life-threatening transfusion reactions generally occur within the first 5 to 15 minutes of the infusion, so the nurse or someone designated by the nurse usually remains with the client during this critical time. Because a transfusion reaction can occur at any time, however, nurses monitor clients frequently during a transfusion and instruct them to call for assistance if they feel any unusual sensations. No Table 16.9 on page 331. Types of reactions: incompatibility, febrile, septic, allergic, moderate chilling, overload, and hypocalcemia. You need to know the signs and symptoms, the causes, and the action. Parenteral Nutrition An isotonic or hypotonic IV nutrient solution instilled in a vein distant from the heart is not extremely concentrated and consequently can be infused through peripheral veins. It provides temporary nutritional support of approximately 2,000 to 2,500 calories a day. It can meet a person's metabolic needs when oral intake is interrupted for 7 to 10 days, or it can be used as a supplement during a transitional period as the client begins to resume eating. TPN, Total Parenteral Nutrition, a hypertonic solution of nutrients designed to meet almost all caloric and nutritional needs, is preferred for clients who are severely malnourished or may not be able to consume food or liquids for a long period, usually longer than 7 days. Box 16.7 lists clients who may benefit from TPN. Clients who have not eaten for 5 days and are not likely to eat during the next week, clients who've had a 10% or more loss of body weight, clients exhibiting self-imposed starvation, anorexia nervosa, clients with cancer of the esophagus or stomach, clients with post-op GI complications, clients with inflammatory bowel disease in an acute stage, clients with major trauma or burns, clients with liver and renal failure. Because TPN solutions are extremely concentrated, they must be delivered into an area where they are diluted in a fairly large volume of blood. This excludes catheters that terminate in peripheral veins. The TPN solutions are infused through a catheter inserted into the subclavian or jugular vein. The tip terminates in the superior vena cava. The type of catheter is referred to as a central venous catheter. Sometimes peripherally inserted catheters called PICC, P-I-C-C, is used. This long catheter is inserted into a peripheral arm vein, but its tip terminates in the superior vena cava. Lipid emulsions. Lipid emulsions are a mixture of two liquids, one of which is insoluble in the other and can be administered parenterally. The combination allows a vehicle for administering lipids or fats, which is often missing from parenteral nutritional solution. A parenteral liquid emulsion is a mixture of water and fats in the form of soybean or safflower oil, egg yolk, phospholipids, and glycerin. Lipid solutions which look milky white are given intermittently with TPN. They provide additional calories and promote adequate blood levels of fatty acids. Lipid solutions are administered peripherally or in a port in the central catheter below the filter and close to the vein. If the lipid solution is squeezed or mixed with TPN solutions in larger volumes than those moving through the catheter, the lipid molecules tend to break and separate in the solution. The client receives an administration of lipids, may have an adverse reaction within 2 to 5 hours of the infusion. Common manifestations including fever, flushing, sweating, dizziness, nausea, vomiting, and headache. Also chest and back pain, dyspnea, and cyanosis. Delayed reactions up to 10 days later are characterized by enlargement of the liver and spleen, accompanied by jaundice, reduced white blood cell and platelet counts, elevated blood lipid levels, seizures, and shock. Nursing implications. Question, is the following statement true or false? The venipuncture device is inserted in hand veins in infants or small children. Your answer is false. The venipuncture device is inserted in scalp veins in infants and small children. And this is the end of the slideshow.